Our next academic session is dedicated in the memory of Dr. Gokhale sir. I would like to request Dr. Ashok Deshpande sir to please say a few words.
Good afternoon, everybody. And I am surprised, even after a good lunch, so many faces are here. I was expecting hardly 5-10 faces here after the lunch. Thank you very much. We are starting our third session over here. And as I told you that we have lost 4 of our colleagues in last 20 years. The first session was dedicated to Dr. Maskar sir. He was the past president of our city branch. Second session was dedicated to Dr. Pansopkar sir, who was the director of the mission hospital, and he was the former secretary of our branch. And yesterday's workshop was dedicated to Dr. Jayanti Kulkarni. And we had a sad demise of Jayanti Kulkarni 4 days before our state conference, which we hold in 2000. So it was really pressure on all of us how the conference will go. But with the grace of the God, we had a very good conference in 2000. Now this session we are attributing to Dr. Gokhale. Dr. Gokhale was ex-military man, and he has worked in Indo-China War. He was called from Sangli for the Indo-China War. And he worked in Sangli for about 49 years. About 49 years he was working. And he was known to everybody, and he is very famous, very familiar with everybody, very sweet speaking. I had never seen him scolding. Otherwise, my face is always scolding. His face was always cool. So we are dedicating this session to Dr. Gokhale. Thank you.
We move to our session. The topic for the session is failed spinal anesthesia. The speaker for the topic is Dr. G.L. Ravindran sir. I request our session chairperson, Dr. Sanjay Gadre sir and Dr. Vikas Kurekar sir to please come on the stage. Dr. Sanjay Gadre sir is alumni BJ Medical College, Pune, practicing anesthesia since 1988 in Dhule. He is professor and head of department, ACPM Medical College, Dhule. He is a recognized UG PG teacher, examiner for MD anesthesia in MUHS. His allied interests are sports and musical instruments, and he has been felicitated as Hall of Fame at Ganga Hospital. Dr. Vikas Kurekar sir is retired professor, head of department and MS at GMC Medical College, Miraj and Civil Hospital, Sangli. He has guided 33 PG students and 52 DA students. He is moderator for degree and diploma examination. He has published and presented many papers in journal, state and national level conferences. He is founder member of ISA Sangli Miraj branch and ISCCM Sangli branch. His areas of interest are medico-legal aspects and preemptive analgesia. Thank you so much. I request the chairperson to please introduce our speaker.
Good afternoon, everybody. The speaker for this session is Dr. Ravindran, Chief Consultant at Janali Anesthesia and Critical Care Services, Shimoga. He is former professor and head of the department of Shimoga Institute of Medical Sciences. His areas of interest are obstetric anesthesia, airway, regional anesthesia, and he has conducted more than 13,000 labor epidurals. Past president ISA Karnataka branch in 2003. He was organizing secretary KISACON 18 in 2002. May I request Dr. Ravindran sir to start his speech. Thank you.
Good afternoon, everybody. I'm really honored. 1 hour after the lunch, and I see a full house. Thank you so much. And I take this opportunity to thank the Sangli City branch for having invited me here. My good friend, Dr. Raju Koparde, who was my fellow colleague during our post-graduation days, and every one of the Sangli Miraj City branch for having invited me here. It becomes my responsibility to keep you all awake for the next 25 minutes. Thank you. Let me see. See, it's over 120 years since the first spinal was given on the 24th of August 1898 by August Baer, none other than him, on his assistant Augustus Hildebrand. Now, after subarachnoid injection of cocaine, what he did, Baer did, he burnt the cigar on the shin of his assistant, Hildebrandt. He kicked on his testicles, and then he hit on the shin with an iron rod. Whereas during this, the wrestling, the boxing championship, Weidman had a fracture of the tibia. He really, winced. He could not bear the pain, whereas Hildebrandt did not. That was the success of the spinal anesthesia. This is the success story. The history of successful spinal anesthesia is also the history of failed spinal anesthesia also. Because the first spinal was a dual spinal. The boss gave it on the assistant, and the assistant gave it on the boss. And the assistant's the spinal failed. Both had PDPH. The fact that both had PDPH proves that both had done a dural puncture. But why did assistant's spinal fail? It was claimed that this was the equipment or the operator failure. And even today, probably, that's the most important reason why our spinal fails. And over years, spinal anesthesia has seen a roller coaster journey, climbing to its pinnacle at one point of popularity, and then coming down to abysmally low levels of popularity at the other. And today, the most popular anesthetic in the whole world is spinal anesthesia. So why is it so? Why spinal is so very popular? It's because it's a very simple technique. Has a definite end point. You see the subarachnoid, you see the CSF dribbling. It's one of the most reliable technique. And you get the complete surgical anesthesia with a very small dose of the drug. And these are the reasons why spinal anesthesia is so very popular. The incidence of failure with spinal anesthesia is extremely low, perhaps less than 1%. True, but this has been quoted by most journals, articles. But a figure as high as 17% failure rates are quoted by in one of the teaching hospitals in the United States. I don't know what is the quality of anesthesiologists there. 17% failure rates, I think none of us would be practicing spinal anesthesia. Now, coming to the management of failed spinal anesthesia, this particular article, it's an excellent article. This article in 2009, with over 450 references, it advocates 4 different maneuvers. 4 different maneuvers like repeating spinal, change of the posture for a better spread, local anesthetic infiltration, systemic sedation, all of them before going on to the general anesthesia proper. So this is a very important thing, that before giving general anesthesia for a failed spinal, you have many other things to do. Now, what do we normally do when our spinal fails? What do we do when our spinal fails? The first thing that we do is look at the brand name. This brand does not work, this brand does not work, this is a bad one. And you see, I had told my sister not to give this drug any time. And she gives me the same brand and I fail again. And these are reactions that we have. Look at the manufacturer, which we had never done earlier. Batch number, expiry date, what not. We see everything else. We see this patient's back again. The moment I saw the back of this patient, I knew it's just like this, the spine is. I knew it is going to fail. So we start blaming everything except me. Blame everything else except me. This is what we do. I did everything. I did my best. What can I do? See, this is one WhatsApp group, Anesthesia Academics. I think at least 10 or 15 of the audience must be members of this group. And it's an excellent group, believe me. You don't get hi, don't get good morning messages, don't get happy birthday messages. Only academics are discussed. And such an excellent group, with all due apologies to the group, I'll tell you one important fact about it. Between 2016 June and July 2017, in that 1 year period, there were 14 reports of failed spinal anesthesia, all attributed to local anesthetic agents. All brands, batch numbers, everything were blamed. And most of the times, the other group members also added their voice in blaming either the batch member or manufacturer or something like that. See, Neurosciences Division of AstraZeneca received 562 product defect notification reports between 2001 and 7, a 6-year period. All failed spinal anesthetics, all attributed to ineffective bupivacaine solution. From 54 countries, the reports came. What they did was, they appointed a neutral agency to investigate. Sample from the same ampule which was used for the spinal was taken back, and the report was stunning. Analysis showed that the returned material was within the product specification in every case. Then how can you blame the drug? See, this is what happened. So think why my spinal failed before going on to. There are two failures we know, the types, the total failure, the partial failure. Most of the times, total failure is because that the drug, local anesthetic, has not reached the subarachnoid space at all. We have not deposited it. The partial failure is because it has not reached the subarachnoid space in sufficient quantities. Now, these are the two reasons why our spinal fails. And this amounts to 99% of all our failures, and that one small percentage where you have some definite reasons like inadequate interthecal spread, anatomical abnormalities, septae, local anesthetic resistance, whatnot, and poor quality of the drug is also one of the reasons, but that all this probably accounts to only 1% of the failures. Gaston Labat in 1922 has told 2 conditions are required for your spinal anesthetic to act. 1922 he has told. One is puncture of the dura mater, and you must have put the drug inside, the subarachnoid matter. And after 1 century, it is true in 99% of all the cases. Now stop the blame game. You point one finger at somebody else, 3 fingers will be pointing at you. Now, how to go about, what to do? There are 2 landmark articles on failed spinal anesthesia, both coming from India. One in 2014 by Dr. Sunil Pandya and Ketan Parikh in Anesthesia World Clinics, and the other one is 2018 in the Indian Journal of Anesthesia, this time by Ketan Parikh and Shweta Sitaramaya, on approach to failed spinal anesthesia. Excellent article, every one of you should read them. They have divided the failed spinal management into 2 groups from the time of recognition of failed spinal anesthesia. One is if you recognize it before skin incision, and if you recognize it after skin incision, what is to be done? Now let's go ahead and discuss each one in detail. The first one is if you recognize, see, the failure to do a deep dural puncture is probably the first type of failure. Now why fail to do a dural puncture? Normally, what we do to do a spinal anesthesia, for every one of us, it's the same thing. We go between the 2 spines, through the interspinous ligament, and want to reach that space, that narrow space in the, between the 2 laminae, interlaminar space, that gap, and then reach the ligamentum flavum, puncture it to reach the epidural space, puncture the dura mater to reach the subarachnoid space, and do it, right? This is what we normally do. Now, for which the most important thing required is patient cooperation. So what we need to do is immediate preoperative counseling. If you do a good preoperative counseling, go and stand by the side of the patient, talk to him or her nicely, touch her, nicely talk to her, and explain to her what you are going to do and what she is expected to do. Then the patient cooperation will be much better and your spinal will not fail. I mean, the dural puncture will not fail. So good rapport you develop. You position the patient yourself, tell her what to do, what not to do, how to position. Supposing with all this you hit a bone. Who has not hit a bone during spinal anesthesia in this? Anybody who has not hit the bone? No, everybody would have hit a bone. Now, when you hit a bone, what is your reaction? First thing that we do is, before somebody sees, we pull out the needle. And we start looking here and there. Nobody should see us. Hitting the bone, we don't want somebody to see. So instead, what we do, we go on poking here and there, except the bullseye, we hit everywhere. Now, this is the reason why we fail repeatedly. Instead, if we learn from the mistakes, that means we hit a bone, why am I hitting the bone? Where am I hitting? Which direction if I go, it is better. So we can learn from the point of, there are four possibilities, there are three possibilities you see. Probably you are hitting the lower spine or the upper spine or on either side the two lamina. Now if you hit a bone, the first thing that you need to do is manipulate the needle carefully. Okay? First thing that you do. You hit a bone, manipulate it carefully. And if you are successful, fine, fantastic. Supposing you are not successful. You hit the bone again. Now, from the point of view of the depth of the needle, at which point you hit this bone again, the depth from the depth, you can arrive at certain information. So what you need to do is, you ask first time, you see what depth the needle is. Second time, what depth the needle is. Observe these two things. You might have hit the bone at a deeper level, at a superficial level, or at the same level. Three possibilities. Agreed? Now let's see what happens. Supposing you hit the needle, you hit the bone at one point, make a cephaloid deflection, hit the bone again at a deeper plane. In that case, you are hitting the lower spine. You need to go a little more cephaloid, your possibility of hitting the dura mater is greater. Supposing you hit the bone at some deeper plane, second time cephaloid deflection, you hit it at a superficial plane, you are hitting the upper spine. So you need to go a little down. Then your possibility of hitting the dura mater is greater. Supposing now you hit the bone at one point, you turn it cephaloid, and then you hit the bone again at the same depth. In that case, the two flat structures on either side, it is the lamina. So you are hitting the lamina now. So what you need to do is, you must deflect it towards the midline. It could be leftwards, it could be rightwards. Try the rightwards first. You are successful, fine. If not, try the leftwards, you will be successful. So you learn from your mistakes. Don't erase your mistakes. If you learn from your mistakes, probably you will feel better. The next thing is positioning the patient. You are doing it in this lying position. You are not successful in getting the spinal. Make the patient sit up. Doing it in the sitting position. Make the patient lie down. See, this change of position makes it a little more better. Use an ultrasound. You see, these days ultrasound is like ripped jeans. It's trendy. Earlier it was only for trips and for vacations. Now even here you can wear ripped jeans. It is like that. Today ultrasound is like that. It is trendy. Use it everywhere. Ultrasound is a very, very useful tool. It gives you the depth of epidural spinal space. You use it once or twice. In simple cases, you will know the importance of it. It's very useful. And especially in obstetric setup, each and every obstetrician has the curvilinear probe with the low frequency probes, and they are the ones which are to be used for ultrasound of the back, spine. You can easily identify the epidural space, the depth, the direction, the point of insertion. Especially in obese, it will be very, very useful. The second one is, now, apart from the dural puncture failure, next is total failure. You got a good CSF flow, there is no action at all, you call it total failure. Now, how to test the level of the block? This is very important. You check the motor power, you check the pinprick, light touch, cold swab. Pinprick and cold swab is not very sensitive, pinprick is not very human, motor power and light touch are the best. Now, when to test? If you test very early, very soon, and more frequent, the patient will become very nervous. Wait for some time. Before declaring it as total failure, you must at least wait for 20 minutes because the drug has to get fixed. That is when you can declare that my spinal has totally failed. Very frequent, very early testing is not very useful. Where to test? See, I am an obstetric anesthesiologist basically, so forgive me for giving cesarean examples everywhere. So you test at the phalansteal incision site, it is supplied by thoracic segments. So if there is pain in the thoracic segment, does not mean that it is total failure. You understand that? You have to test the sacral sparing. With lumbar spinal, with heavy bupivacaine, heavy solutions, any local anesthetic, there is no sacral sparing. Segmental spine is not possible at that level with heavy bupivacaine. So if the sacral roots are spared, it is total failure. Okay? Life is like a camera, you see. You focus on what is important, capture from good times, develop from the negatives, from your mistakes. And if things don't work out, take another shot, do another spinal. Subarachnoid block is also like life. Focus on position of the patient, landmarks, direction of the needle, feel of the tissues, all these things. Be prepared for difficult cases. Take time to perform. Use all your experience. Learn from your mistakes. Improve every day. Still, if it fails, give another spinal. It's not a difficult thing. Now, if after 20 minutes there is no sacral anesthesia, you call it total spinal, you can give a spinal again. Now, when I say repeat spinal, what is the dose? For a total failure, you can give the full dose again. Whatever dose which you have chosen earlier for that particular procedure, for that particular patient, can be given again. When there is a total failure, of course, you can use epidural. If you are well versed with epidural, I have done lots of epidurals. I prefer, if the spinal fails, I prefer place an epidural catheter. I feel I am a little happy with it. Do a combined spinal epidural, it is even better because you have the opportunity of giving another spinal and then you have a backup epidural. The next possibility is partial failure. The reasons for partial failure, number one reason is too little of the drug. You're too careful, you don't want high spinal, you don't want hypotension to occur, you want to give a smaller dose. Many a times, the inadequate level of the block results. If you give anything less than 1.5 ml, that is about 7.5 to 8 milligrams or 9 milligrams of bupivacaine, your chances of partial failure is about 10 to 15%. Improper fixing of the needle. You don't fix the needle properly to the syringe and then try to inject. The drug leaks and there is a possibility of partial failure. Level of the dural puncture has an important obligation. Now you see, the highest point of lumbar lordosis is L3-4, right? At that point, if you give the spinal L2-3 or L3-4, then the possibility of the drug ascending up is a little higher. Supposing if you inject the drug in the L4-5 or L5-S1, then the drug selectively, in the supine position, selectively settles to the sacral trough. Then the possibility of partial failure, that is inadequate level of the block, is definitely there. There's one possibility, what is known as the dural sleeve. And this happens especially with the pencil point needles with a side eye. The eye is at the side of the needle, right? Supposing if the eye is lying somewhere near the dural sleeve, you have just punctured it. Now, when you try to aspirate the CSF, because of the negative pressure, the sleeve moves outward and the drug, you can aspirate the CSF. But when you are trying to push the drug, that time the sleeve moves out. The dural sleeve moves out and the the needle, eye, opens to the epidural space, most of the drug is given epidurally and only a small quantity is injected into the subarachnoid space. This is another reason why even with a good flow, you might fail. Now, how to manage the partial failure? If it is before 15 to 20 minutes time, that means that your level is, you are not achieving. You know that you are not achieving a sufficiently good level in about 10 minutes or 15 minutes time. That is the time when your drug is still not fixed completely. That is when you can think of salvaging your block. Now, how to salvage your block? There are 3 ways of salvaging your block. To improving the spread, there are 3 or 4 different ways. Number 1 is time. Give adequate time. Give adequate time for the drug to get fixed. Don't be in a hurry. If your surgeon, as Dr. Meenakshi said, is holding the knife and standing there, you engage her in a different way. Allow her to sit down for some time. Then the drug will spread nicely and it may act. Counsel the patient and reassure her at that time. That's very important again. Now, there are different ways of facilitation of the block, spread of the, you can facilitate it. How to facilitate the drug block? What do we do normally? The inadequate spread. Normally, we try to give a head down tilt, right? I think every one of us do that, right? Now, let's see whether head down tilt really helps. This is the spine. In the cross-sectional view of the spine, in the supine position. You agree with me? With the cervical lordosis, the thoracic kyphosis, lumbar lordosis, and sacral kyphosis. Agreed? This is how it is, right? In the supine position. Now, supposing you inject a drug and the drug has selectively gone to the sacral region, trough, and the level has not come. This is the situation. Now, you try and give a head down tilt. Does the drug ascend over the lumbar lordosis and come up? No, it doesn't happen. You give a little more tilt. In an urgency, we try to give more and more head down tilt. Even then it will not ascend. If you give an extreme head down tilt, the drug may ascend very much high and you may get a high spinal block also. So, head down tilt is not a very good choice to facilitate the block. Now, let's see what happens in the lateral position. The moment if you put the patient in the lateral position, what happens is to the horizontal plane, the spine is flat. All the curvatures are in the horizontal plane. Now if you give a head down tilt, slight head down tilt, the drug spreads up. So putting the patient in the lateral position and giving a slight head down position will facilitate the spread of the block. True. But how practical is it? After 10 minutes, for a cesarean section, you would have given a spinal anesthesia, the patient is put in the supine position, surgeon will naturally would have painted, draped. How can you put the patient in the lateral position? It may not be possible. There is another method. What you can do is, in this position, you slightly flex the hip. When you flex the hip, what will happen? The pelvis rotates. When the pelvis tilts, the lumbar lordosis is reduced to a certain extent. The lordosis is reduced. Now you give a head down tilt, the drug ascends well. Give a flexion of the hip, then give a slight head down tilt, and this will facilitate the spread of the block. The third maneuver is Valsalva maneuver. You ask the patient, you all know Valsalva maneuver. If you give a Valsalva maneuver, what will happen? It will increase the intra-abdominal pressure. When it increases the intra-abdominal pressure, it increases the spinal subarachnoid pressure also. The drug nicely, with the CSF, it spreads. The next one is supposing if you have given a CSE and the spinal component is partially acting and you have an epidural catheter, in that case what you can do is, you can distend the epidural space with saline or local anesthetic itself. When you try to do that, what will happen? The the epidural space is distended, and the epidural space distended will push the dura mater inside. And this will compress the subarachnoid space. The drug with the CSF with the drug spreads. And this is how probably you can increase the spread. Of course, we all do this. systemic sedation, Entonox, local infiltration of the skin, all of them can be done, but with a caution. Systemic sedation and Entonox can always be done. Now, after 20 minutes, if it is after 20 minutes, there is partial block only, you have to be careful. You cannot salvage the block. Now the drug is, most of it is fixed. Now you can repeat this. You can repeat a spinal. Now here it is very tricky. For a total failure, you can always give the drug, the fixed dose itself. Whereas for a partial failure, you don't know how much has gone inside. You don't know how much is there. How much is too much? How much is too little? You don't know. Now what is told is that if the block is only lumbar, that it is not in the thoracic level at all, in that case, you can always give 60 to 70% of the original dose, or up to about 7 to 8 or 9 milligrams of bupivacaine for a cesarean section. Again, excuse me for giving cesarean section examples. Up to 9 milligrams of bupivacaine heavy can be given for a partial failure. Now repeating spinal, how many times it can be repeated? Anybody has repeated spinals? Anybody has repeated spinals? What happened? Yes. And believe me, at least 25 of this audience would have repeated it twice, thrice, a few of them. But what is important is that officially, the literature support is there for only one. Supposing you're given a spinal, you're given a repeat spinal twice, thrice, and you document it, or somebody comes to the court of law, you may not get a good support. So officially, only once. Now what are your concerns? High spinal, total spinal, cauda equina syndrome, PDPH and infection with repeat dural punctures, all of them are a possibility. You can always give an epidural. If it's partial failure also, you can place an epidural catheter and gradually graded epidural topping up can always be done. Systemic sedation, Entonox, even in the partial failure can always be given. But a bit of this, a bit of that can be a recipe for a disaster. So you need to be very careful. Never over sedate without either an endotracheal tube in place or at least an LMA in place. Be very, very careful about it. If nothing works, of course, you have your general anesthesia. Why is this called a mask? Any one of you? Very simple. It masks all our deficiencies. Spinal fails, mask it. Epidural fails, mask it. Block fails, mask it. You don't need to bother whatever Dr. Bala has told. If it fails, mask it. If it fails, mask it. No problem at all. So, general anesthesia is always there. Now, the last part of my discussion, after skin incision, if you feel, you get that, your spinal has failed, first thing that you do is ask your surgeon to stop the surgery. Patient is in pain, ask the surgeon to stop. Stop at that moment, do something, reassure your patient. Tell her or him that you are with her, you're going to take care of the pain. Convince her, talk to her nicely, and then get her confidence. And then, just one more minute, please. One more minute. Reassure the patient. If the pain is pressure only, then you can think of salvaging the block, local anesthetic infiltration, sedation, everything. GA should be the last choice if the pain is something like a pressure only. If it is a sharp pain, general anesthesia. Don't think anything. Have a low threshold for conversion to general anesthesia. So you have various avenues to manage. Why general anesthesia is the first choice? So these are all the take-home messages. Thank you very much. I take this opportunity to invite you all to this beautiful Jog Falls, which is near my place, Shimoga. just 1 hour, 1.5 hours drive from my place. It's a fantastic place. All of you should visit that place. Thank you.
Nice, sir. Dr. Ravindran, sir, you had very well explained rather the management of failed spinal. And this is really a topic of discussion. And I will definitely ask 5 minutes to organizer to discuss with this. Though he had explained it very nicely. Second thing is that the slides and everything, he made us really not to sleep. And again, thanks for his nice deliberation. Topic is open for discussion.
Sir.
That may be the cause of failure because previously we were using higher bore meters.
Sir.
That will make whether it makes a difference.
Now that is probably true for a beginner for doing a DP. But for other failures, once you have deposited the drug, the failures are the same with 27 gauge needle and 22 gauge needle. But to do a dural puncture, maybe what you said is true, but with time, with experience, with using it more frequently, your failure rates come down.
But sometimes fluval is good, but with smaller bore meters, we are pushing with pressure. So that time also sometimes
Maybe it is true, but that kind of failures, even 22 gauge needle has, sir. Your
Sir, can I ask one question? So,
yes, please. From where?
yeah, here.
Yes, ma'am.
Sir, repeatedly blood coming as a spinal tap, say 2-3 pricks also. I mean, I have abandoned and I have given GA, but is that it comes under failed spinal then? And it has happened twice. Post-COVID, I came to know later. And in emergency section, your co-op profile has not come down in fetal distress, etc.
See, repeated blood aspiration, blood through the needle, can come from any vessel also. Or you hit the, inadvertently you go in and hit the bone, you hit the all other structures in between. It can come. Now your coagulation profile is different from blood in the needle. If your coagulation profile is abnormal, if you are thinking that way, it is totally a different issue. But blood in the needle alone should not prevent you from trying again. But at least you change the position, change the needle, maybe change the operator, call person with a gray hair. Ma'am, yes.
Lower thoracic and lumbar and lower lumbar. So if it is in all the 3 pricks, if it is blood.
No, see, blood alone,
Frank blood.
Yes. See, how many times you can go ahead and do the dural puncture, how many attempts, there is no literature supporting that. Nobody says, for airway management, you fail twice, you do this, LMA 3 times, all these definitions for airway management are there. But for spinal, it is not there in any textbooks that you can only try 3 times, 4 times, third time you try, you change the position, call for, that is not there. But blood alone in the needle does not prevent you. But at the same time, if you suspect some coagulation abnormality, stop it at that moment. Stop it at that moment.
Sir, one question.
Sir.
Hello. Only one question. You said less than 0.5% incidence of brand getting blamed, but many times we find one anesthetist get problem with one drug, with one batch, and suddenly we find from 3, 4, 5 hospitals the same batch and same drug, the spinal gets failed. So obviously we...
See, the drug supposing if the drug is of poor quality, what does it mean? The company has probably not put in sufficient quantity of the drug in it, or not good, not a conducive atmosphere for the drug to be stable. Local anesthetic drugs are very stable. There is no expiry date for local anesthetics as far as the stability of the drug is concerned. Sterilization, yes. I don't say that you go and give expired drugs, but it is only from the point of view of stability, I'm telling. So they are very stable drugs. That's number one. Number two, they are very cheap drugs. 20 milligrams of bupivacaine is there in one ampule. If he puts 15 milligrams in that, what is he going to save? Nothing. It is peanuts. So, quality of the drug is not a concern at all. It is very little. And it's only a chance that it has been observed. But the same, one batch drug will go into thousands of ampules. Some 2-3 people in and around Sangli fail, does not mean same batch has come to Shimoga also. It would have acted there. So you understand my point. No, I'm sorry if I hurt your feelings. That's not the issue. The issue is to blame the drug should be the last thing to do. There are many other things which can be salvageable, which are to be done.
Sir,
Okay, thank you, sir.
Sir, one question. Sir, last question. Sir, here.
Ask the chairperson.
One question, sir.
If you go on asking, it will be only the last session then.
Sir, any relation with scorpion bite?
Very truly, very true. I mentioned about the local anesthetic resistance. You saw that? One of the slides I mentioned about it. Local anesthetic resistance is a definite possibility. Not necessarily with scorpion bite. Scorpion bite and local anesthetic resistance is proved. It is definitely there. It's definitely there. No. See, why I did not go into all that is, we should focus on the more important things. That is why I didn't talk about that.
Correct, sir.
And apart from that, there are genetic local anesthetic resistance in some patients. In Spain, there is one person. They have reported that person. You give 10 milligrams, you give 10 ml local anesthetic, local infiltration, nothing will happen to him.
Okay.
He has a total resistance to local anesthesia.
Okay, sir, thank you. And the last question by Sadhna Kulkarni, madam.
Ma'am. Ma'am.
One of the cause of failed spinal is wrong drug injection.
Definitely, yes.
Perfect.
Perfect.
It is not only the cause for failed spinal, the failed reputation and everything. If you give tranexamic acid, that's it.
Yes.
You are not an anesthetist after that.
Sir, add to your presentation. At this point, your presentation.
Sir, thank you very much.
Thank you very much.
Very much interesting topic.
Thank you, sir. I'm sure your inputs will be a game changer for all of us in our practice. I now request our chairperson to please felicitate the speaker. Thank you, sir.
I request Dr. Koparde sir to come and felicitate the chairpersons.
It is not to praise Ravindra, but you give him any topic, he will make it this lively only. Any topic in anesthesia.
Thank you so much.